Right now, too many physicians have too few choices. And I want physicians to have the best possible menu of options available to them. Independent practice is incredibly rewarding. It can be sustainable in the right way, and if built the right way. We just want to try to find ways to be pro-physician.
Before we jump into the episode, I want to thank our sponsor, Evidently. Evidently is the clinical data intelligence platform built to help physicians harness the ocean of patient data they're drowning in every day. From chart summarization to AI-assisted note drafting and denial appeal support, Evidently makes sure the right data shows up at the right time. Physicians using Evidently report spending less time hunting through charts and more time focusing on patient care. That's why they've become a trusted partner to health systems looking to improve documentation, quality, and revenue sustainability. The company is led by providers and AI researchers that are dedicated to reducing documentation burden and helping clinicians practice at the top of their license. If you want to see what Evidently can do for your hospital or your practice, reach out today at www.evidently.com. Now, let's get into today's episode. Before we jump into today's episode, I want to give a huge shout out to our first ever How I Doctor podcast sponsor, Abridge. Abridge is the leading AI platform that drafts structured, clinically useful notes at the point of conversation. Clinicians remain in full control because they review and finalize every note. With Abridge, many clinicians report reclaiming time and reducing their documentation burden, myself included. I've been using Abridge in my role as a practicing emergency physician in San Francisco, and clinicians who use it report up to an 86% reduction in effort writing notes, a 78% reduction in cognitive load, and 70% decrease in after-hours documentation. The company was also founded by a physician and is completely dedicated to empowering clinicians, which is what makes them the perfect first sponsor for How I Doctor. If you aren't yet using Abridge, inquire with your IT department today or reach out at abridge.com/contact. Thank you, and now let's get to today's episode. Welcome to How I Doctor, where we're bringing joy back to medicine. Today, we're talking about a trend that I've been seeing emerge over the past few years. Physicians thinking about going independent, which is kind of ironic since when I was growing up, almost every doctor was already independent. I see this trend from several specialties, but the biggest growth is in primary care. And in a How I Doctor First, we've got not one, but two guests in one episode. My first guest, Dr. Umar Bowers, is an internal medicine physician from North Carolina who actually went independent. After years in a large medical group, he decided he wanted more control over how he practiced, more time with patients, less bureaucracy, and the ability to build something of his own. Umar also didn't go it alone. He got some help from Aledade, a company that helps physicians become and stay independent. Dr. Bowers opened Dawson Medical Group, and with the support from Aledade, he's now running the kind of practice he always envisioned. Joining him is Dan Bowles, General Manager of Practice Health at Aledade. Aledade was founded by Dr. Farzad Mostashari, an internist and, of course, most importantly, former podcast guest. In the interview, we'll talk more with Dan and his team launching Project Turnkey, which is a program designed to help make that leap into independence faster, simpler, and a whole lot less risky. Whether you have dreamed about opening your own practice or you just want to understand what's possible outside of a health system, this conversation is an honest reflection about what it means to take back control of your career in medicine. Dr. Umar Bowers, Dan Bowles, welcome to How I Doctor, guys. Thanks for being here.
Thanks, Graham. Happy to be here.
Likewise. Thank you.
Umar, maybe I'll start with you. Take us back to, before you decided to go independent and start your own practice. How do you describe the medicine you were practicing before, when you were at a large health system?
Sure. There were two chapters in my life before we opened our own organization. The first one was for a large system, was in a group that was pseudo-autonomous, meaning this group was purchased by the system probably 20 years prior to me coming on board. But there were signals that there was going to be less and less of the pseudo-autonomy, which was a little concerning because I think I loved the concept that I signed up for. And as my career, developed there, those changes started to manifest and decided that I wanted to be closer to the decision making. I felt like having agency and autonomy was very important for a young physician. And the second chapter was actually the medical director for a small independent practice for several years.
Oh, interesting. Yeah, I mean, 20 years ago, that's a long time. That sounds like a kind of a fairly early kind of acquisition from a health system. And it sounds like over those 20 years, maybe the health system started to think like, hey, if we own this thing, we want to have more control over how it works. And
So the system owned numerous primary care organizations throughout the region, and they were, discussing sunsetting the legacy names and also just bringing, from a streamlined standpoint and from a lean standpoint, I actually understand it. It actually made sense. But if you were kind of on the side of the equation that we were, we kind of liked the way things were. So it wasn't necessarily that we disagreed, but we just didn't love the way things were going.
was it a feeling that you had, or was there a moment that made you realize like, hey, this isn't going in the direction that I'm actually happy with?
I remember I was rounding in the hospital. I was ambulatory clinic mostly based, working outpatient Monday through Friday. On the weekends, I often rounded as a hospitalist. So I was in the call room rounding on a early Saturday morning, and I actually ran into one of my GI partners, and he was livid based upon some recent conversations that had happened with the administration. And it was essentially, we need you to cover this other hospital within our system, and their group was X amount of GI docs. They had just hired another, fellow coming out of training, and their call schedule was contingent upon covering this many hospitals. But the system said, "Well, we don't care. Rework the contract. Rework the agreement. We need you all to cover this hospital." So he was outraged, and it was palpable. And more importantly, I also learned that this group, the owned group, right, my partners, had to cover the hospital because the independent group said, we don't want to cover that hospital anymore. Right. So it was clear one group said, for whatever reasons, I'm not sure, we no longer want to cover this hospital. And then so therefore the owned group had to do it. And it was no choice. It was one of those, doomsday scenarios where they come in and say, this is what's happening, no choice, no conversation, make it happen as of next week.
Yeah, I would imagine as a hospitalist hearing a GI doc complain, who's maybe making the hospital pretty good money with procedures and stuff like that, for the GI docs to be upset. That would make me certainly think like as a hospitalist or maybe an ER doc, like, oh man, if they're saying this to GI, what's going to come next for the hospitalist or the emergency medicine?
Precisely my sentiments. And if the sentiment and the approach is we're going to treat the subspecialists, and some of them were my friends, others, they were like gladiators, right, working their butts off, making a ton of money for the hospital and not doing bad themselves, to be honest with you. But I had that exact same thought as well. How will they treat me when it comes to, right, when I'm on the table next? And that was really the beginning of me saying, all right, what's the future look like for me?
Umar, I want to ask you, what is actually independence mean to you at the end of the day? I think we hear that a lot. Doctors want independence, we want autonomy, but like, what does that word mean? What does that allow you to do because you're independent and you're your own boss?
For me, it means the ability to control my schedule. It means the ability to hire additional staff. If I want to see more patients on Wednesday or be off on Wednesday, I can flex patients different times of the day and the week, and I don't have to ask permission. If I want to add an additional nurse or medical assistant, and I know that comes out of the pot of money that we have allocated toward that, right? It may decrease cognitive burden, may make my life a little easier, but I have the ability to do that. If I want to innovate and I want to partner with some third parties who are doing things at the cutting edge of health tech, I can do that. We can host students, which we've had a very strong relationship with the local universities here, precepting students. I don't need to have a bunch of hoops that we jump through in order to do that. So, other docs may think independence means something different, but across the board, it's just the ability to be at the table for all decisions, because independence has different flavors, right? There's independent physicians. We've got 6 clinicians in our particular group: a physician, 3 PAs, and 2 NPs. Other independent docs are multi-specialty with a bunch of different specialists. Some docs are just one doc shops, and that's okay.
Yeah, I mean, what I heard is you get to control the rules, set the schedule, and then you get to kind of pick and understand your trade-offs.
Without a doubt. Nothing about me without me. So whatever the decision is, you got to live with it. You got to, deal with the consequences and repercussions, but you do have the ability to be involved in the decision making.
It's interesting owning the decision. We're expected to do that every day with our patients. Like we have a fundamental professional responsibility to help our patients. We have an ethical and a moral, and we take a Hippocratic oath. So, that is a really good point that like we already do this for so much of our day and our ethos. You could imagine why a physician would want to have that for all of the day as well.
Without a doubt. And historically, that has been the case, right? 2020 apparently was the year where there was the inflection point. The majority of physicians were now in owned employment agreements versus physician owned employment agreements. And so, we're in a new paradigm, if you will. I don't know if we've kind of recast the mold for what the archetype is for a physician, but we're now in an unfortunate scenario where less and less house officers and med students are thinking about independent primary care or independent subspecialty care. And I feel like there's an opportunity for us to paint a different picture because there's a lot of upside, in my opinion.
Yeah. Umar, one last question, and I want to ask you about Aledade as well. Like, was there a particular fear in your head when you said, like, hey, I think I'm going to leave the health system? Was there one or two things that were the predominant things that made you worried about this decision?
Believe it or not, Graham, I didn't have any worries, and perhaps that's due to this irrational self-confidence that I've had. And it's relative. It's relative to what I know
Yeah.
I do well. I don't get on the plane and ask the pilot to scoot over. I got this, right? But when it comes to doctoring and how I doctor, and when it comes to taking care of patients, I felt comfortable that whether it was in an outpatient setting or whether it was as a hospitalist, that was always, maybe this irrational confidence because hospitalist medicine would always be there, right? That's not going anywhere.
Sure.
And that's something that you can plug into at any point. But I actually did not fear it. I felt very comfortable moving forward.
That's great. Well, let me just ask you about Aledade, and then I'll bring Dan into the conversation too. When you first heard about Aledade, like what stood out or what maybe surprised you about the company?
So when I first heard about Aledade, I was about 5 or 6 years out of my training. And it was at a time where I was at the smaller private practice as the medical director. And after doing it for a few years, you kind of get into a rut on the hamster wheel. And what I was excited about is that we were doing something as simple as, FMEA, failure mode effect analysis, and some PDSAs, basically some really granular quality improvement process work and looking at how to improve outcomes from a value-based care standpoint, but also looking at how we do that and kind of peeling the onion back all the way to the core. And so that was the exercise that really like locked me in. It was at no point at that time that I think about I'd be launching my own clinic or that I'd be working as a medical director for Aledade, which happened later, or now as an ambassador. It was mostly I love the process, and there was a lot of data and science. Institute for Healthcare Improvement, all those things started to come back to me, and so I appreciated that, and that was really what the spark was.
A quick word about today's sponsor, Evidently. Their platform turns an ocean of fragmented clinical data into concise, actionable insights. Chart summaries, note drafting, denial appeal support, HCC capture, so you spend time caring, not chasing. A transplant surgeon at a large academic medical center recently took transplant referral review from 2 hours to 20 minutes with AI-assisted chart review from Evidently. Physicians deserve workflows that improve accuracy, reduce exhausting chart biopsy, and help us practice at the top of our license. If you want to see how this might work in your hospital or your department, go to evidently.com. That's evidently.com to get started today. Hey, today's episode is brought to you by Abridge. We all feel the weight of clinical documentation that follows us home and chips away at our personal time. With Abridge, clinicians can change that. Abridge drafts a structured, clinically useful note at the point of conversation, all seamlessly integrated into Epic and customizable to your specialty while you review and finalize every word. Clinicians have reported significantly less after-hours charting, improved satisfaction, and dramatically lower burnout. Let technology support your day instead of interrupting it. Visit abridge.com to learn how you can focus more on patient care and less on paperwork. Let's put the care back in clinical care. Yeah, let me bring in Dan to this conversation. Maybe for folks that are not familiar with Aledade, can you give us some background on the company, how it works, what it does, and then, maybe a little bit about your role as well?
So Aledade got started in 2014, helping physicians get access to and succeed in new payment models. That's a very kind of policy wonk space, super complicated. I'll get into what value-based care is in a second. But over the last 10 or 11 years, we've really come into our own helping physicians do exactly what Dr. Bauer said, which is stay independent and take care of the patients the way they see fit in their communities. Um, so over the course of the last 10 or 11 years, we've worked with more than 2,400 practices in 46 states. We serve a little more than 3 million patients in these new payment models. So what is a new payment model? What is value-based care? It's a complicated concept that can be described very simply as helping put physicians in an aligned incentive model where doing right by patients creates better economic outcomes. So we participate in something called the Medicare Shared Savings Program. We're also active in Medicare Advantage and in other value-based care arrangements across other lines of business. And in those models, we give physicians access to data, access to support, coaching, analytics, and ultimately aligned incentives where when their patients do better, they end up doing better. And just by way of, maybe one last set of data points, 2024 is the last data for which we have, or last year for which we have publicly available data. Um, Over a million patients were in agreements with Aledade. We saved the healthcare system more than $1 billion. Overall, we share about half of that with the physicians that we work with. That's a 20, 30, sometimes 100% increase in top line revenue for those practices. And more importantly, at least at the macro level, we help save taxpayers more than $320 million. So in total, Aledade is in the alignment business. So we work to align the interests of health plans, patients, and physicians in a way that's good for everybody.
Yeah, I mean, I was kind of embarrassed to admit when I talked with Farzad on the podcast, I didn't know anything about the Medicare Shared Savings Program, MSSP. I didn't realize that there are laws and policies that are trying to help Medicare save money, and then some of that savings can get passed on to the people that help do the savings. And so you guys are keeping physicians independent by giving those physicians some extra cash in their pockets because they're able to also deliver some of that savings, and then they can access that capital as well to keep their practices running, to help support their growth and retention of patients too.
That's exactly right. In a fee-for-service world, independent practice is essentially negotiating for whatever they can get out of the health plan. Maybe you get a 2%, 3%, 4% increase every year if you're lucky. Inflation alone has been almost twice that, if not more than that, in the last couple of years. You can see really quickly how you get upside down in that model. Um, what we love about the shared savings construct started in Medicare and now it's starting to make its way into other lines of business. Um, is that it ultimately rewards physicians for doing what they do best, which is taking care of patients in their community. And we found that physicians who are independent, who are clinically autonomous, deliver the best care for patients. And that ultimately does the best in these models.
Yeah, I think it's really important. I mean, like, look, you guys know this. The Medicare reimbursement rates continue to go down for physicians. That drives physicians into the arms of health systems and other people who get reimbursement hikes from Medicare. And since often private insurance is based on Medicare rates, like it does feel like this is one of the few ways that physicians can stay independent. Feels like Medicare has been kind of driving physicians into large health systems and large groups, whether they understand what they're doing or not. It feels like that has been the trend, just economically speaking. If you are getting less income and more cost, it's going to be hard to stay independent.
There's absolutely the concern about decreased fee-for-service reimbursement. Also, on top of that, we're seeing increased burden, right? Which is right, which is not cost neutral from a standpoint of either physicians' cognitive burden or hiring a team member to do that thing, that prior authorization, or whatever the case may be. So it's a paradox. I think there's been some really good intentions, but there has been some challenges with decreasing reimbursement. The market and commercial plans often follow that.
Dan, what kinds of challenges do you hear from physicians who are like, maybe they're the 10 or 15 years ago Umar who are like, hey, this sounds kind of interesting, but maybe couldn't make the leap, or they're curious but not ready just yet. Do you have examples for what they frequently ask about?
Sure. So I'll bifurcate the world into those folks who are independent, but haven't yet jumped on the value-based care train, and those who are employed, or in other way, shape, or form tied to a health system. For the independent docs, it's really not even really knowing where to start. And from a big picture standpoint, it feels like a lot of work to transition your practice. You need access to better data. Maybe you don't trust that you have the right EHR.
Because you have to prove to you're obviously proving to Medicare that you're doing the stuff to become value-based care, and that requires data to prove that you're doing some savings, and then that is how you're able to get cash passed on to you, right?
Yeah, that's right.
Yeah,
And,
yeah,
I probably should have said this at the outset, but um, all these models are predicated on improving quality and reducing total cost of care.
yeah, yeah.
The easiest way to reduce total cost of care is to provide higher quality care that reduces hospitalizations and ER visits.
Keep your patients healthy. Yeah.
Keep your patients healthy and out of the hospital. And nobody's better positioned to do that than an independent primary care practice, but you need scale to get access to a lot of these models and meet the actuarial needs of the models that you were just alluding to. So that takes a lot of data, it takes a lot of know-how, it takes a lot of infrastructure. And frankly, if you haven't gotten started at this point, or maybe you've had a false start with another partner, it can really feel daunting. For the folks who are employed, it's interesting. Every time we go to a gathering of physicians, whether it be an association meeting or even an Aledade function, two or three or four docs will pull us aside and say, "Hey, this sounds really cool, but I have no idea how I would even get out of the arrangement I'm in right now. I'm not happy. This is not what I signed up for. Can you help me?" And that really, sparked the idea for us a few years ago to launch what we're calling this turnkey model, which is helping physicians start their own private practices, go back to independent medicine the way it used to be, as you said at the outset of this call. Um, and so with the turnkey model that we've helped Dr. Bowers and other physicians with, it's really about offering them four big picture things. First is clinical autonomy. They don't want to trade, one employer for another, right? Like this is at the end of the day, letting the physician drive the decision-making process. Second's transition support. So uh, it can be daunting to look at the list of things that you need to do to go start an independent practice, all the way from provider credentialing to finding a building to figuring out what EHR system you're going to be on to navigating billing. All that can be really complicated. We've got a team that's there and has done it before many times and can help advise you. Um, Third's an economic model that makes sense. So we provide some startup capital to physicians as they're just getting going. But as I said it earlier, the fee-for-service medicine world doesn't really make sense for independent primary care. Value-based care world's very different. We're seeing significantly stronger practices from a financial standpoint by virtue of the shared savings checks that we and other ACO enablers distribute. So we feel like that economic model is really strong for the physicians that are getting started. And then the last and possibly the most important is a community of physicians who are like-minded, who've been there before, who've done this before, either like Dr. Bowers have started a new practice in the last handful of years, or like so many of the other physicians we work with have been independent for 20, 30, 40 years, right? So there's a network of mentors that are just kind of ready-made and available to you.
It almost reminds me of like Umar, when I first became an attending, like I finished residency and everything, I was like, wait, what am I supposed to do with my free time now? Am I supposed to keep reading? And it took me like 6 months or a year to be like, oh, I think I'm allowed to do whatever I want with my free time. Like I think we go through so many hoops for, you know, 2 decades of medicine, and like, oh, what now I have to study for boards, and now I have to do this test, and now, it almost reminds me of like transitioning to independence is like, well, wait, how does my schedule work? When do I see patients? And then you have to be like, oh, I can have my schedule work however I want it to work. I get the opportunity to I have the responsibility, but I also have the opportunity to make the schedule how I want to. Like it does remind me of probably having to relearn some muscles that maybe our profession used to have that have atrophied over time of like, hey, yeah, I need to figure out how to do a schedule and when I'm going to see patients and how all that's going to work. And maybe Alade's helping with some of the pieces that physicians used to be good at and have kind of not been as familiar with recently.
Yeah, there's a lot of tools available, and some of them are, practice facing. Some of them are, for the staff, for the team, and some of them are, for physicians. And I also think there's a self selection of some physicians that want to do this. Those that would easily, either pick up a book or attend a conference or find some sort of CE or CME in order to kind of really get professional skills and training on wherever they may have a gap.
Umar, when you joined Aledade, what changes about how you're doing billing, coding, the data that you're collecting? I mean, is there a lot that changes for you, the physician, or is it stuff that you're kind of just like sending the data to Aledade and Aledade is then doing stuff and then magically a check appears every month or something?
Sure. On the spectrum of independent practices, Aledade may encounter a physician who's never heard of the term value-based care, and you have to introduce them to the topic and the concept. And there are a lot of new workflows in that scenario and the importance thereof. And frankly, the sustainability and survivability of their practice may be on the line. So it would behoove them to listen and learn. And then in other instances, there are, practices that have been doing this good work, or, maybe they've been with a fellow traveler in the accountable care organization enablement space. They just either want a different partner or need additional help in tech and services. So there are resources that Aledade provides to help physicians perform better in value-based care arrangements. I like to say Aledade doesn't write the rules, right? Aledade gives you a blueprint or a playbook to win, upon which the rules are written.
Dan, I liked your point about just having a network, a community of colleagues. Like, you guys know this. Like, doctors, we trust and listen to each other way more than we probably should. Like, I think it's way more common for a doctor to ask another doctor about like financial advice or where they get their brakes changed or something like that than like a mechanic or a banker, because we just have this weird implicit trust that we have with each other. And I think we're also more likely to maybe like admit that we don't know something or admit like, hey, Umar, how do you handle this in your practice? I don't know what to do, versus, doctors generally don't like to say I don't know about anything because we feel like we're culturally supposed to be experts and know-it-alls.
You know, uh, I've been with Aledade almost since the beginning, and is a testament to really Farzad's leadership. Um, Nobody knows better how to care for their patients than a physician in his or her community. We don't know any better, but the things that we know how to do are data. We know how to do data. We know how to do technology. We know how to do analytics. We know how to do contracting. We know how to do the credentialing work, um, prioritization of different algorithms behind the scenes. Those are not things that physicians, went to medical school to do. So in our minds, it's always been about a partnership. And let's find a way that physicians can continue to care for their communities in the right way that they know best. But let's find ways to help them as often as we can. And anytime we can create a forum, this is a key early learning of ours, which, in hindsight is one of those like, duh moments. But every time we'd get a group of physicians together, uh, whether it was, on a Tuesday night for, a board meeting or Saturday morning to talk about, care management, um, folks would come early and stay late, and they weren't talking to us, right? They were talking to each other, and it was great. Like, it was so wonderful to see. And we've been lucky enough, and I think, again, credit to Dr. Mostashari's leadership. smart enough to try to bake that into not only the product of the company, but also the ethos.
Look, I think practicing medicine is hard. I think it's never been harder, but there's also a part of it that I think most doctors really enjoy it. And we also enjoy connecting with other colleagues who are going through those same challenges, but that we see the great incredible stuff we get to do to help other human beings at the same time.
That's right. And, in the context of what we were talking about a moment ago with turnkey and helping physicians go back to independent medicine, there's an old saying that you can't measure the desire to cross the river by the number of people who have swam across. We see a lot of physicians that are looking longingly at Dr. Bowers and his peers saying, gosh, how do I get there? And we're trying to provide a bridge, right? Like we're trying to build a bridge to help them get there in the fastest, easiest way possible.
Dan, just like really obvious, like numbers. Do you guys have numbers that you quote or share about what the pre-post Aledade revenue looks like? How do you guys frame that side of it for physicians that are interested in working with you guys?
Sure. So, at a very high level, the cost savings that I alluded to before, we split it 50-50 with the physician partners. Our 50% pays for all the technology, the data, the staff on our side. The 50% that we send to the physicians is theirs to do with what they think is best. Last year, on average, it was a few $100,000 for the average practice, and for practices who've been with us for 4, 5, 6 years, it's north of seven figures. So it can be significant revenue to the practice. Um, and the nice thing about that is that it's all generally net new and it is not replacing. It's not like you're trading $5 of fee for service revenue for $5 of value based care revenue. This is incremental on top of
Yeah, it's
and
like almost like a
allows
new
physicians.
revenue stream or something.
It's a brand new revenue stream that
Yeah.
grows, right? So the longer you do
Because
this,
you
the
get
better it is.
better at the value-based care? Is that it grows because you're understanding and have a better relationship with Aledade and understand how the system works more?
So think about it like this. Um, Dr. Bowers talked about some of the new workflows that we bring into bear in a practice. One is pretty basic, which is just the core wellness visit. And, how do you do a wellness visit with a comprehensive data set behind you in a way that will prevent a hospitalization this year, next year, 3 years from now? So those wellness visits compound over time. The longer you do them, you're doing it every single year with your Medicare patients, you learn a lot more about them and you're preventing hospitalizations, not just this year, but next year and the year after. The more you do them, the longer that compounds, the more successful you get against a cost benchmark. You just do more proactive primary care, right? Like let the physicians be physicians, give them the data that they need to take care of their communities in the best way that they know possible.
What's the time frame kind of look like? Say a listener emails you tomorrow and says, "Oh my God, I'm all in. I'm sold. All I needed was the podcast." Like, what's the time frame to kind of get up and running?
We estimate 3 to 6 months. Just it takes a lot of planning, takes a lot of careful consideration. If you need to get a building, if you need to find a lease, credentialing can take a couple of months sometimes. There's a couple of longer poles in the tent, but once you've kind of made the decision and commitment, we can move as quickly as you want to. So we can and have helped stand practices up in 90 days. It's a blur. It's fast, but it's certainly doable. But I think the bigger question for us is less about how quickly can you get going, and more how do we build the right foundation under you. And if that takes us 3 months, great. If it takes us 6 months, that's okay too. We want these practices to be long-standing members of their community. We want these physicians to have stability and control over their lives in a way that is sustainable. You know, it's a uh, it's a valuable thing for these physicians to kind of leave employment. We understand that, and we know that they need some help. We have recently launched in Michigan and are helping some physicians create new independent practices in Michigan. For those of you who may not be familiar, One of the large health systems that was in the state has recently left. Many of the physicians who were a part of that system have been found themselves scattered across a number of different other health systems that operate much differently, and that has created some disruption in the market. One physician in particular reached out to us and said, I'm over it. I want to do this on my own. Uh, and there were two straws that broke the camel's back for her. One was she's been operating in essentially what amounts to an old FEMA trailer for the last handful of years, and the new system didn't know that. A year after they technically acquired the practice. And you can imagine all the issues that she faced from a logistical and operational standpoint with that. The second was the contracting dynamic. She said, I was made to feel like the enemy. And just a really heartbreaking story on a number of levels. And we've been able to help her start the process of getting to her own private practice. And I feel like it's going to be a real boon for her. It's going to be a really great thing for her community. And, I think for other physicians that find themselves on a similar stance, it's a show of hope that, you can find your way out of a not so great situation.
I certainly wish that medical schools and residencies had more education and training on kind of the business of healthcare. I mean, because it is a business in this country. If doctors say they're not business minded or they're intimidated by finance or running their own business, how does Aledade kind of de-risk that or help them feel more confident or more comfortable in that space?
The first thing I'd point to is really tactical. So, from a scale standpoint, we have relationships with health plans in almost every state. So, we're going to be able to secure contracts that are reasonable, that are favorable in the context of outcomes based payment, and that we think you can be successful in. We're also able to bring on board, the credentialing staff that's necessary to help support the process, the EHR, the billing support, all of that sort of work. Um, and I think the last kind of maybe tactical piece is know-how, right? Like we've been there, we've seen it, we know what works.
And I think learning what you know and learning what you don't know and then engaging subject matter experts has to be something you're comfortable with. And Aledade is well resourced and has helped us with that, particularly in the beginning. Granted, I learned the term force majeure, right? That's fine print in the contract language from payers, right? And from credentialing bodies, and nothing was happening, right? So then there were times in which we had a solid plan that we pro-formed out and we thought that we had everything in place. But because of supply chain logistics or global, increased demand and decreased supply for certain talent in certain areas, things were not getting done and it affected us getting paid. And so Aledade was a partner that helped us then engage with another party that could work around the roadblock.
In our last few minutes, I've got one question, same question for each of you. Umar, I'll start with you. In one sentence, why should every doctor at least consider independence today?
At the risk of sounding contrarian, I don't think every doctor should,
Oh, I love
to
that.
be
Tell
honest
me.
with you. Uh, this is, yeah, it's not a sentence, but
Yeah,
if you'll
please.
allow me, the idea is independent primary care has an amazing amount of upside. It allows you to craft the life and lifestyle as a physician, as an owner, or a partner in some instances that you want, but it's not for everyone. I don't mind my practice manager calling me at 7 in the morning or at 7 in the evening, but I have some colleagues that are physicians that they would absolutely not want that time to be interrupted. And so for them, right, maybe owning their own practice or something similar to that would not be the right thing. What I'm advocating is that the subset of doctors who would otherwise want to be, independent physicians and owners, whether again owning their own shop or being a partner in a group practice, that opportunity should be there for them. But I believe AI is going to be a force multiplier. I believe it's going to level the playing field. I do think some of those burdens that we've historically ran to large healthcare systems so we don't have to deal with those struggles and those challenges. I've seen over the past couple of years AI really begin to level the playing field.
Dan, how about you? Why do you think doctors should consider independence?
I love the way Dr. Bowers framed it. It isn't for everyone, but at the end of the day, right now, too many physicians have too few choices. And I want physicians to have the best possible menu of options available to them. Independent practice is incredibly rewarding. It can be sustainable in the right way, and if built the right way. And as I said a few moments ago, we just want to try to find ways to be pro-physician.
Yeah, I love that. I mean, I'll agree with you both. I mean, one of the reasons I made off call is I want doctors to keep practicing medicine. Like, I think it's so important that we have thoughtful, smart, caring physicians who still continue to enjoy seeing patients and helping other people. And right now, I feel like with between burnout and all the other challenges, a lot of physicians are leaving the practice. So I'll just end it there and thank you both, Dr. Umar Bowers, Dan Bowles. Thank you guys for being here and talking with me about what you're trying to do to preserve and improve physician independence, and just help more physicians find ways to find meaning in their practice too.
Thank you.
Thanks, Graham. This was a pleasure.
Thanks for joining me today. For interviews with physicians creating meaningful change, check out offcall.com/podcast. You can find How I Doctor on Apple, Spotify, or wherever you listen to podcasts. We'll have new episodes weekly. This has been and continues to be Dr. Graham Walker. Stay well, stay inspired, and practice with purpose.